Happy Friday, everyone. Welcome to Virtual Morning Report. Rafa and I are going to, no, I'm just kidding. I'm just kidding. As you all know, part of our journey here in the Virtual Morning Report is to elevate everybody, and that includes our own team members. And so at some point, with little to no forewarning to them, they usually find out like literally minutes before that they'll be co-discussing with one of the facilitators. And often it's a source of great anxiety, but they of course knock it out of the park. And today I was planning on trapping my dear friend Rafa to discuss with me, but he is the first VMR team member to slip from my clutches. I could not catch him. Why? Because we have a very special guest today on RL himself, because Reza's not here. And our special guest is my dear friend Amanda, who is, I think, a legend in VMR. She was featured on the most recent episode that featured on the podcast, where she was sitting outdoors to the tune of birds. And I'm not sure who that is. That's not Amanda. I would recognize her voice instantly. But Amanda, Rafa tells me you have a case, and the only downside is he knows it. Do you want to unmute yourself, introduce yourself to the weekday VMR crew before we jump on in?
Hi, everyone. I am Amanda. I am from Brazil, and I love present case. I love to participate, and today I'm very excited with this case, and I hope you'll enjoy.
Thank you, Amanda. How is your day going so far?
Good, very good. I'm so woo.
Yeah? You have a lot of energy, huh?
Yes.
Are you nervous?
So. I'm comfortable.
You're comfortable. Good. You know, I get nervous still, even today. So I have my tea, and I have my snuggle buddy here right here. Look at this guy. He was so bad this morning. I'm not going to talk about him. I'm not talking to him right now. What makes you comfortable today?
Be here with people, and I love to talk, and I love participate at VMR. It's comfortable to me.
Amazing. Can you tell me something bad about Rafa that I can make fun of him in the future?
No, he's so nice. Yes.
Oh man, wow. There, you had your chance. You had your chance, but it's okay. Look at him. You made him blush. Look, he can't even look. Okay. Yeah. Anne Marie has a great suggestion. You owe Amanda some money now, my dear friend. Oh, well, you know, Reza's not here, my dear friend, so you're going to have to do with me. And we should jump on in. So I'm ready whenever you are. Do you know how many aliquots you have, just to help me not ramble like I did last time?
5.
5 total, or 4 plus answer?
No, it's 5 aliquots, and the last one with final exam.
Okay, all right. Let's do it. I'm ready if you are.
Let's do it. So first aliquot, we have a 50-year-old male comes to the ED complaint of abdominal pain for 1 year. And the first aliquot.
Wow. You know, it's incredible whenever patients show up for something that is so long-standing, and yet they choose to show up today. And if you pretend that the threshold for somebody to show up is this, and you ask yourself, well, what happened that the patient broke the threshold? And it's not uncommon that that the time course is actually murky, because we expect most people with abdominal pain to show up more quickly. And so the fact that somebody chooses to show up for a year makes you wonder whether the severity of the abdominal pain has been mild enough that the patient has chosen not to come to seek care. Or that actually the patient has an acute on chronic component and the time course gets conflated. So my advice to you is, whenever you're dealing with a complaint whose time course you expect to be earlier, Stop and reflect and ask yourself, is there acute on chronic dimension before we assume that the pain has been long-standing for a year? But if we do that exercise, because we've talked about abdominal pain extensively, if we do that exercise to say, hey, okay, you know what? Let's assume that the physiology of the diagnosis is actually one that presents in a year, and the patient isn't presenting in a delayed manner because of access to care or because of an acute component to the chronic disease. What does it mean for something to cause abdominal pain for over a year? What does that mean? How does that change the calculus? And I have to tell you, it changes it dramatically. Um, I'm not sure who should, okay, there we go. So what does chronic abdominal pain fundamentally mean? If you think about all the causes of acute abdominal pain that we tend to diagnose, most of them end with an itis. Cholecystitis, cholangitis, pancreatitis, appendicitis, diverticulitis, so on and so forth. And itis usually means acute inflammation. And that acute inflammation readily shows up on CT scan. So the first thing to recognize is the probability of the arc of diagnosis that we usually do to get an answer for abdominal pain, acute abdominal pain, which is to get a CT, is much less helpful in chronic abdominal pain. Let me show you visually what I mean. So the probability of CT positivity finding the answer for abdominal pain goes down and down and down and down as the time course evolves. It's not zero. That's because most things that we find on CT abdomen pelvis is an itis, and that itis is usually acute. Okay? So what's the lay of the land of chronic abdominal pain? It's things that are not in the abdomen itself as the most common cause. Anterior cutaneous nerve entrapment syndrome is a pathology we may or may not talk about later, but it's actually a pretty common cause of chronic abdominal pain. And in women, endometriosis is the most common cause. Outside that, you'll recognize the schema. This is a schema for CT negative abdominal pain, because most of these conditions, if you look at them quickly, you'll see that they tend not to show up on a CT scan. The luminal diseases, vascular diseases, endocrine diseases, medications and toxins, neurologic diseases, and some other rare things. So where are we? We're in the land of chronic abdominal pain, but the ground beneath us is not solid. Why? Because most people who present with a time course that is unusual for a specific complaint usually means that either they have an acute component to it, or they have reduction in access to care that results in an atypical presentation of something that should have presented earlier. But if we accumulate more data that allows us to be confirmed that this is actually truly chronic abdominal pain, then we'll follow the lay of the land we just outlined here. But right now, we have to be open to the possibility that the time course is atypical, not because of the physiology, but rather because of access to care or an acute complication on top of a chronic syndrome. All right, Amanda, back to you.
It continues. So the patient reports that for a year, he has been having colic abdominal pain of moderate intensity localized in the upper abdomen. This is associated with past diarrhea with fall odor lasting 7 to 10 days, improving with antispasmodics. This patient also informs that a week ago he presents asthenia, pallor, edema up to the knees, and increased abdominal volume. He also reports weight loss, 11 kilograms, and denies fever. Non-past medical history, non-meds, non-allergies, or recent trips. And he lives in rural area, and he doesn't have a healthy diet due to financial conditions. He also reports bad sanitary conditions. He drinks socially and is a non-smoker, and his brother died of pulmonary tuberculosis.
Oy, oy, oy. Amanda, you're such a great presenter. You're presenting so clearly and so well, and you're Quite the storyteller too. One question I have for you is what made it better? He got antibiotics or it got better by itself?
Antispasmodics.
Oh, okay, okay, got it. Antispasmodics. Okay. That's such a fancy English word. I can't even imagine how to say antispasmodics in Portuguese. Look at you. That's awesome. Thank you. Okay. Ay, ay, ay. Where do we begin? The schema that I showed you for chronic abdominal pain no longer applies. This is not chronic abdominal pain. This is recurrent episodic abdominal pain with very concerning features. If you look back, IBS, endometriosis, anterior cutaneous nerve entrapment syndrome are all things that will cause abdominal pain for life without the evolution of extra abdominal symptoms. When somebody has chronic abdominal pain, and that's their chief concern, they have nothing else going on. It's just the abdomen that's bothering them. So I think the caution that was advised about labeling something as chronic has borne fruit. This is not chronic abdominal pain. This is episodic colicky abdominal pain associated with weight loss, pallor, and lower extremity edema. And that's very different than chronic abdominal pain. What progress can we make? We know that there is chronic diarrhea involved with this. We know that there is edema involved with this and likely anemia given the pallor. But what is the most important thing to help us understand everything we just listed? It's the weight loss. Folks, if I told you this person has lower extremity edema, you would tell me that you expect their weight to go up. So you should be panicking at the amount of weight loss this person is having because they're losing body mass despite retaining fluid. In most people who have lower extremity edema, their weight goes up. So the weight loss here is extreme because it is still present despite the accumulation of water weight. So in many ways, you can take this and say this is a diarrhea syndrome characterized by weight loss. Chronic diarrhea plus weight loss. Chronic diarrhea is often classified as either osmotic, secretory, or inflammatory. A secretory cause of diarrhea can cause weight loss, but usually the problem with secretory diarrhea is you just lose fluid. You have no reason to lose weight in a secretory diarrhea because your only problem is dehydration. So if you drink back the fluid when most people are, you don't lose weight. Weight loss plus chronic diarrhea prioritizes an osmotic cause versus an inflammatory cause. The question is there reason to suspect one over the other here? And the answer is osmotic causes of diarrhea are unusually associated with pain. Pain is typically suggestive of an inflammatory cause. So here, I think the signal for a chronic inflammatory diarrhea with episodes of abdominal pain is probably the way to go, but I'm not sure about that. This could be an unusual case of secretory diarrhea where the weight loss is because of a neuroendocrine tumor. It could be an atypical presentation of osmotic diarrhea that happens to be painful, but usually isn't. But more likely that we're in the lay of the land of chronic abdominal pain with diarrhea that is inflammatory. So what's the approach to inflammatory diarrhea? It's the 4 I's. A chronic infection, a chronic autoimmune disease, infiltrative diseases like amyloidosis and certain cancers, and a whole grab bag of other categories that I won't expand on. And like anything, the priority is to think about infection, knowing in the back of our mind that inflammatory bowel disease is a no misdiagnosis. Are there any clues to help us make more progress now? And I'd say not really. Where are we? We thought this was chronic abdominal pain, and most patients who have chronic abdominal pain have nothing else going on. And we've disproven this as chronic abdominal pain, and it has turned out that this is more a chronic diarrhea with features of abdominal pain and weight loss. Chronic diarrhea is inflammatory, secretory, or osmotic. The presence of pain and the associated weight loss pick out chronic inflammatory diarrhea as the most likely culprit. And in that category, a chronic infection is the most important thing to think about. And when you're thinking chronic infection, the first thing you want to know is what is the epidemiology of the patient and do they have any immunocompromising conditions? So that'll be really, really important. All right, Amanda, back to you.
Fantastic. So in the physical exam, we have our heart rate, 8 BPM, blood pressure, 110/80, respiratory rate, 16, sets, it's 98% on room air. Engine, oriented, poor nutritional status, cachetics, and HEENT, pale mucosis is tucrosis. Cardiovascular and pulmonary exams are both normal. In abdomen, we have distended abdomen with a fluid wave, normal bile signs, pain on deep palpation in upper abdomen, and we have hepatomegaly. Skins and extremities, we have bilateral pitching edema up to the knees, 3 cruces. And this aliquot.
Yes, this aliquot and make Robbie's head spin like no other. I walk into rooms many times triaging patients, and unfortunately, big bellies are very common. Big bellies are usually because of excess adipose tissue. Sometimes, least commonly, they're because of accumulation of air in the belly from an ileus or a bowel obstruction. But the easy way to know what phase of matter is involved, solid, liquid, or gas, is to look at the legs. And if you see liquid in the legs, it's probably liquid in the belly, and you can confirm that with a fluid wave. So remember that if the belly is distended, ask yourself, what phase of matter is occupying this space? Is it solid, liquid, or gas? Don't forget to consider pregnancy in young women, but usually the solid material is increased adipose tissue. If it's gas, it'll feel tympanic. If it's fluid, you'll see fluid in the legs and you'll feel a fluid wave. So this person has ascites. Oh, this person has ascites, one of my favorite things in the world, because the most common cause of ascites is portal hypertension. And portal hypertension, the clues rise to the surface. You don't have to look inside the belly. You can see caput medusa, spider angioma, paromerythema, jaundice. None of them are here. There appears to be no evidence of portal hypertension on the surface, which is a good measure of portal hypertension in the belly. So this probably is an exudative ascites based on the lack of evidence of portal hypertension on the surface, though sometimes people with cirrhosis or schistosomiasis don't have caput and don't have evidence of portal hypertension on the surface. So what causes exudative ascites? Well, we'll confirm that with the SAG, but now when you say the word exudate, what does that mean? I want you guys to forget about the case for a second. Okay, just put it on hold. When there's fluid in a space it shouldn't be, it always comes from a vessel, always. If there's fluid in the belly or fluid in the peritoneum or fluid in the pericardium, fluid in a potential space that's not supposed to be, the source of the fluid is a blood vessel. How do we determine what that fluid is? We look and we study the nature of the fluid. And let me tell you what that fundamentally means. If the vessel isn't leaky and pressure is forcing the fluid out, it's a transitive. If the vessel starts to get leaky, it leaks more proteinaceous material, and that results in a high LDH, high protein, and that we call that an exudate. And if the vessel bursts open and everything is fair game, we call that hemorrhage. So when there's a fluid in an incorrect place, what you are really looking for is you're looking at what is the integrity of the blood vessel. Is the blood vessel intact? And so the fluid that you sample has nothing in it. It has no LDH, no protein. If the fluid that you sample has a little bit of protein and a little bit of LDH, you're like, oh, okay, you know what? The vessel's a little bit leaky. It's probably some inflammation going on. Or if the vessel's burst, there's blood. So it's really simple. You don't have to remember transit versus exudate. The real question is, how leaky is the vessel? And here, we don't have evidence of pressure. If there was pressure involved, we would see the pressure on the surface. There's no reason to suspect that this person is hemorrhaging so much into their belly, they would be hypotensive. So even before the sag is here, you're probably dealing with an exudate because there is no evidence of pressure and there's no evidence of bleeding. And we confirm that with the serum ascites albumin gradient. So what causes an exudative ascites? Ascites is then the question becomes, why is the vessel inflamed? And you go back to our trusted trifecta of infection, autoimmune, and malignancy. And so then the question is, what kinds of infections, autoimmune disease, and malignancy cause episodic diarrhea and ascites? And that is a really fun exercise that I'll leave for now. But now the next step is to tap the acidic fluid and study it for the sag to confirm our working hypothesis it's an exudate, and then we'll go from there. All right, Amanda, back to you.
So the labs, we have white blood cells, 700, bands, 2%, neutrophils, 68%, eosinophils, 2%, lymphocytes, 27%, hemoglobin, 10.1, platelets, 100,000, urea, 16, creatinine, 1.4, total proteins is 3.57, albumin 0.95, and globulin is 2.62. AST is 21, ALT is 16, and alkaline phosphatase is 100. Finish.
Oy, oy, oy. So the CBC is notable for anemia and a little bit of thrombocytopenia, both of which are expected at this point. You can have anemia of chronic disease, and this patient certainly has chronic disease. And then really the normal abnormality is the albumin. And the key question is to be like, yo, where'd the albumin go? Most people have albumin, a low albumin because of chronic illness and malnutrition. And the second most common cause is low albumin because of liver disease. Here, we can suspect a nutritional contribution to albumin because the patient's probably not eating well, but the albumin is never this low, never this low. So marked hypoalbuminemia is usually because of liver disease or loss of albumin. Now, where can you lose albumin? Where do you think you can lose it? You can lose it in the urine, you can lose it in the GI tract, and you can lose it in blood vessels. So this patient has marked hypoalbuminemia. And the key question, my friends, is it because of a drop in production from inflammation or intake? Is it from liver disease? This is a very rare congenital disease. Is it from nephrotic syndrome, from protein-losing enteropathy, or vascular leak? Here, it's so severe that nutritional causes are unlikely. There's no evidence of liver disease at all. I doubt this patient has a genetic disease presenting at the age of 50. We should get a UA to look for evidence of nephrotic syndrome, but we have so many GI symptoms. And the GI symptoms make us worry about the possibility of protein-losing enteropathy. And protein-losing enteropathy presents very similarly to what we're seeing here, where there's a GI component to the disease, but results because of the loss of albumin in ascites and lower extremity edema. So I think the next step is to understand where the albumin is being lost. And we look at the UA to look for protein loss there. And if it's not there, then we look at the GI tract for protein loss there. And that's when we measure the stool alpha-1 antitrypsin level. And the stool alpha-1 antitrypsin level, if elevated, suggests protein loss in the GI tract. And of course, let's keep track of the ascites. We have to get to the bottom of that too. All right, Amanda, back to you.
So I have one information. Since an endemic disease was suspected, the SAAG was not performed. However, if it had been done, would be lower than 1.1 and could be show some eosinophilia. Fine. So we have a stool exams, and we have numerous haptoids larvae of Strongyloides stercularis. And we have the stool cultivation with the Arada-Murray technique with several filarioids larvae of Strongyloides stercularis.
Wow. So you found strongyloides in the stool?
Yes.
Wow, that's absolutely incredible. Is it? I assume this is the final. This is your diagnosis, or is
Yes.
there more?
No, yes, the diagnosis is the disseminated strongyloides,
Yeah,
but
that was
included.
that was incredible. So can you, so can, maybe let's just pause there. And can you teach us why you? It sounds like you were suspecting it, but you said that we were suspecting of an endemic disease. So Amanda, can you teach us what you were worried about and why you were suspecting strongyloides?
So it's parasititis such as schistosomosis, leishmanias is very common in my region. So always we suspect. And I think it was a very interesting case, and we learned a lot because I think we expect eosinophilia in parasitic disease, especially strongyloiditis. But in this case, is a chronic parasitosis. In the most of times, comes with a normal eosinophils. That's why it surprised me and have a disseminated strongyloiditis, clinical forms of presentation associated with a state of severe immunosuppression, like the patient, and is chronic case is typically asymptomatic, but in some cases cause a GA symptoms, like in this case.
Outstanding. That's a great overview of strongyloides. Can you tell us what you learned about strongyloides causing ascites?
It's because it's due the high parasitic load. So it's so high that can cause ascites in the patient.
That sounds absolutely fascinating. Wow. I am blown away by this case. I think it's a humbling reminder to take great caution about where you start. And for me, I heard chronic abdominal pain and I immediately started to think about endometriosis and IBS and whatnot. Then you told us that it's actually chronic abdominal pain, but the context is very concerning. And the context has abdominal distension, has diarrhea. And we learned that abdominal distension can come in many different phases. But you told us there's ascites plus abdominal pain plus diarrhea. And then you taught us the value of the SAG, which wasn't obtained, but very helpful. And then, of course, using the epidemiology. I mean, it sounds like strongyloides is very common in your area. And when you have chronic diarrhea in a patient uh, who has no reason to have IBD and has no reason to have cancer, I think strongy is a very, very good thought. And one of the most common endemic mycoses, one of the most common endemic parasites, actually globally present and also in the United States. One thing to recognize about strongy is that the risk factors for dissemination can be overtly present, like high dose steroids or chemotherapy. But one kind of sneaky way that strongy can disseminate is through co-infection with HTLV1. And so you might think about that depending on where you are in the world and the presence of HTLV1. But the most common kind of hard to identify from the get-go cause for disseminated strongy is HTLV1. So I think about that in some instances. But I don't know how prevalent HTLV1 is in your region, Amanda. And in any case, thank you for a fantastic case. We learned a lot. The chat is going crazy, I see. And I will pass the mic to you, Amanda, if you have any final reflections before we pass the mic to your friend, Rafa, to round out the teaching point.
I think it's you you say everything, and I'm so glad to present in this case because oh, so surprised me,
Yeah,
and only that.
absolutely. Thank you so much for coming. It's such a delight, and I hope to see you tomorrow for our global VMR. All right, Rafa, take it away.
Once more running away from Rabbi since 2021. So thank you, Amanda, for the case. Like really, really interesting. It was such a pleasure to work with you in this case. So we had abdominal pain for 1 year, and then Rabbi reminded us to exclude causes that could lead to severe abdominal pain because patients, they usually go to the hospital sooner than that, like perforation or pancreatitis. And there are this pearl that Rabbi taught us that with time, the probability of diagnosis in acute abdomen etiology with CT scan actually goes down. And then we saw that this patient had edema, weight loss, diarrhea, and we should expect weight gain with the edema. So it's a red flag. And then when it comes to chronic diarrhea, we can divide that into two buckets, inflammatory or non-inflammatory causes. Inflammatory being things like IBD, malignancy, radiation. Non-inflammatory could be osmotic with stool osmolar gap greater than 50 or secretory if it's less than 50. And we saw that this patient had a distended belly. So we have to think about the phases of matter. Is it solid, liquid, or gas? And if we see edema on the legs, it's probably ascites. And the most common cause is cirrhosis. However, this patient doesn't have stigmata of chronic liver disease, like gynecomastia, pulmonary erythema. So we had to look at another etiology. And then it comes back to the SAG, comes down to the SAG, sorry, which is the serum to ascites albumin gradient. If it's greater than 1.1, we have to think about portal hypertension. And it could be divided into three buckets: pre-sinusoidal, like schistosomiasis, splenic or portal vein thrombosis, sinusoidal, like cirrhosis, and post-sinusoidal, like constrictive pericarditis, Budd-Chiari syndrome, and right heart failure. And if it's less than 1.1, we have to think about etiologies like nephrotic syndrome, pancreatic ascites, TB, peritoneal carcinomatosis. And then we saw that this patient had hypoalbuminemia, and the rabbi reminded us to think about three buckets: decreased production, like on a patient with cirrhosis or malnutrition, loss in urine, like nephrotic syndrome, but also protein losing enteropathy, which can be seen, for example, in lymphoma. And then we saw that this patient actually had strongyloids, and the strongyloids can be from asymptomatic eosinophilia to disseminated disease with septic shock. And then there is this thing that can happen with strongyloid, which is called hyperinfection syndrome. It's most commonly seen in patients with immunosuppression, like rabbit tortoise, for example, patients using steroids. And the parasites, like Filaroid larvae, carry the bacterial flora of the bowel to various sites, and it can result in pneumonia, meningitis, gram-negative septicemia, and or disseminated fungal infections. And then there's this pearl that I really love about eosinophilic ascites. There are parasitic causes like strongyloides, toxocaris, schistosomiasis, and other causes as well, like eosinophilic gastroenteritis and idiopathic hypereosinophilic syndrome. But both are treated with glucocorticoids. And there's this pearl that we have to exclude strongyloid first prior to the initiation of steroid treatment because we can precipitate strongyloids hyperinfection. So thank you, everyone. I hope everyone enjoyed this case, and hope to see everyone tomorrow on Global VMR.
A masterclass, my dear friend, as per usual. I would love for you to watch your first ever clip of Teaching Points, then watch that again and see the growth documented on video. And I'm warning you now on tape. I'm not going to let you slip away next time. I can't wait to co-discuss with you, my dear friend. All right, y'all have a wonderful Friday. Thank you for joining us and hope to see many of you tomorrow. Bye.